or discussion, and those two are Penny Schubert, who is a certified genetic counselor in the Medical Biochemical Genetics Department at Children's Hospital, and Jeff Botkin, who is a professor of pediatrics at the University of Utah and associate vice president for research integrity, and who will be leading one of the breakout sessions this afternoon. So we have microphones set up in the aisles for those of you who have questions or points of discussion. If anybody cannot get to a microphone, simply raise your hand, and we have a few people in the back that can bring a mic to you. So go ahead, Lainey.
Hi, Lainey Ross, University of Chicago. I want to thank all the panelists. That was a wonderful morning session. Dr. Alexander, if I'm understanding you, if we're going to have all of these conditions for which treatments are not yet ready and we're going to need consent, does that mean we're going to have a two-tiered newborn screening such that one set will be consent and one mandatory? Or will this open all of it up to an informed consent process, as recommended by the American Academy of Pediatrics, the Institute of Medicine, and the National Academy of Science?
Yeah. I see no need for us to have mandatory informed consent for the existing programs when we are screening for conditions where we have effective treatments. I do believe that when we move to the point, and as I hope we will, where we start screening for conditions where we do not yet have effective treatment, that for that part of the screening and for parents to decide whether they want that information or not, that we need to get parental permission and consent for that part of it.
But don't we already have that with the 25 secondary conditions?
I think states are varying with what they're doing. In many instances, they're screening for these, but without any effect, without any indication that there is even disease associated with some of these conditions, and that information is not passed on to the parents in most instances, as my understanding.
That's not my understanding. But the fact that it is being passed on suggests that we're already doing mandatory screening for conditions that don't meet your criteria.
When the screening itself, that's probably right when it's not being when it's being done just as an add-on to the screening that's done for benefit. My personal belief there is that when we are screening for conditions and we are planning to make that information known to the parents where we don't have effective treatment, I believe that should be done in a research context, which would require their consent.
Dr. Fost, do you want to weigh in?
I was elated when I heard my friend and colleague Duane Alexander say at the end of his talk that the tests should be introduced only in a research setting. Couldn't agree with him more, but that's not what's happening. Forget the add-on tests, just the 25 basic tests, of which MBAD is one example that I cited, has been added in dozens of states, Wisconsin being one of the first, with virtually no knowledge other than 8 case reports of what the sensitivity, specificity, predictive value of the test is, or who needs a diet, or even what the risks of the diet are. We're 0 for 23. We have 23 children identified who have no disease. That happens to be done in a research context only because a colleague got interested in it and got an NIH grant. But the state had no research agenda. I don't know any other state that does. So that's a test among 25 that was introduced, as Dr. Tarini said, really as a research project, but with no formal evaluation, with no hypothesis, no institutional review board review, no standards of informed consent. That's exactly what we did with PKU. We're doing exactly the same thing again. And in Wisconsin, we're 0 for 23 on just one condition. Now, we don't know about the other 24 because nobody's studying them. So I don't know how many other dozens or hundreds of children are being labeled in Wisconsin. I want to say a word about the diagnostic odyssey. This screening program is creating a diagnostic odyssey. These parents would never, these 23 parents wouldn't have gone on any odyssey because they were parents of normal children. But as a result of this now false labeling, fortunately, because they are of relatively low literacy, and don't have access to services, they're probably not seeking much other information. But if they were middle-class, educated, English-speaking people, they would be going all over the place, asking every doctor they could find, what's going on here? The state told me my child has this lethal condition. He seems perfectly normal. I've not been on the diet. What's the story here? And they'd have trouble finding somebody who could answer that question, because the number of people who are expert at this, you can almost count on one hand. So the diagnostic odyssey, there'll be as many of them, maybe way more, created by this testing. And I don't see the research infrastructure for any of it.
Why don't we go over here?
I'd like to thank the panel members for their great presentations this morning. And I don't know how many people in the audience actually work for state government. And I do. I'm the state health officer for Washington State. And some of the issues related to newborn screening are fairly significant in terms of states' obligations. And my question relates to, number one, is this a program, newborn screening, that is ever envisioned to be federalized? Because it is, within the states in terms of their authority today, and you can see by the map, we're in various places, and there are reasons for that. The second is that I think I know the answer before I ask it. It's probably not going to be federalized. And if it's not, to what extent is the federal government willing to really help the states have the adequate capacity to really respond after the screens are positive? Because it takes a whole system to really do this work well. And right now in Washington State, we were very loath to immediately recognize the ACMG's recommendations. And when we put to the test cost benefits, we were horrified by some of the diagnosis that was lacking cost benefit information. And so we had this expert panel, but we didn't have behind it really a lot of the evidence that was really convincing enough to integrate that into a policy decision. So I'm interested to what degree, will capacity be something that will be supported in the ideas of expansion, and to what degree will we have the evidence, true evidence, backing the benefits as we make these policy decisions at a state level?
Who wants to take on Dr. Hayes' question here?
Yeah.
Dr. Alexander and then
Yeah,
Dr. Fost.
let me speak to part of it. I think the likelihood of this becoming a federalized program or with federal mandates is very, very small. The federal government has traditionally looked at these kinds of programs of health as state-based programs, where they have provided assistance to the states and sometimes some guidance, but usually not mandatory sorts of things. So even in the legislation that was just passed, the Newborn Screening Saves Lives Act, there was provision for appropriations to the Maternal and Child Health Bureau and HRSA to continue the support that they've been providing to states for many, many years to help support, not totally support, but to help support their newborn screening programs, including the screening itself and the follow-up counseling. But no intention on the Congress's part of dictating what the terms of those might be.
This is not on it. Oh, there you go. One consistent comment we've heard from Dr. Wylie Burke, from Dr. Beth Tarini, from Dr. Alexander, and myself, is the desperate need for infrastructure. That is, a screening program isn't just doing a test and have a nice day. You need a tremendous infrastructure to interpret the test. You need experts in metabolic and genetic disorders. You need genetic counselors. You need, obviously, financial support for treatment programs. You need assessment of outcomes. Almost none of that has been put in place, and it was not addressed at all in the ACMG report as one of the requirements, and whereas it's inherent in almost all other guidelines. So one thing that's urgently needed is just federal support, because there's not much money in the states to do it, to provide that infrastructure to handle the results of the test. Better funding for fellowships and training in metabolic diseases. There are very few experts in those diseases, and The older cohort is about to leave and with not much replacement. The number of genetic counselors in America is grossly inadequate to help doctors in offices deal with this. Ben Wilfond and I wrote a paper some years ago on just cystic fibrosis alone. If you just wanted to provide 10 minutes of counseling to couples who face decisions about carrier testing with cystic fibrosis, where there's been a lot of error and a lot of bad reproductive decisions, just that alone would occupy all the genetic counselors in the country for about 26 weeks if they did only that. So when you add 1,000 other diseases or 25 other conditions right now, when you add to that 1,000 conditions on a microarray chip, there's just nobody out there who can help anybody interpret this information. So one constructive comment is that's desperately needed is a huge influx of funds from somewhere to provide the expertise to interpret these results for doctors and for patients.
Wylie?
I want to say that I think the conversation, certainly Dr. Alexander's comments, are very promising in this regard, that I think there is an important federal role for creating the database that's needed that Dr. Hayes referred to. And it does make sense to look to federal funding as a very promising way to do some of the needed research that we all agree needs to be done. I would also say that I think Dr. Hayes' comments point to a really important opportunity within the context of significant variation from state to state in exactly the newborn screening panels that are offered. And that is to understand what are the questions that are coming up as states consider what tests to add and what kind of information they need to make that decision, because I think a careful evaluation of that, for example, as Dr. Hayes referred to, the kind of questions that came up for State of Washington's advisory group in considering various tests, might prove to be extremely helpful guidance to the data that we need to answer those questions.
Dr. Botkin next, and then Dr. Fost.
I think the potential federal role here, as others have already outlined, is really quite important and very much welcome. It is new in the last couple of years, and I think the development of the infrastructure in this realm, the registry systems, the development of a multi-center research capability, very much like what was developed for the Children's Oncology Group a number of years ago, really is essential development. So no question that there is significant upsides to that involvement. My comment is really just several-fold to be wary of in this particular context. First of all, I think given the number of issues that we've talked about at an ethics conference here, it's incumbent upon that process to have a robust ethics component. That's not been present at the federal level so far, and I think that many of these issues are indeed problematic, for which there aren't easy answers, but they need to be addressed. And one straightforward one is, what is the obligation to disclose what I would call boxcar conditions? When you have a multiplex test, you get many more results than what you had originally designed the test for. What's your obligation to disclose that to families once you have that information? The ACMG panel assumed that there was an ethical obligation. I'm not so convinced, but I think it's a legitimate and important problem to think through. Two other quick points here. I think a national standard does have advantages from an equity standpoint, but it also has limitations. One may then be confronted with claims that it's unethical to conduct research because it's become the national standard. Everybody's adopted a certain modality of testing. Is it then feasible from an ethical perspective to do a randomized controlled trial? I think Norm talked about this with his presentation. I think we're going to be faced with that challenge down the road. And then the other aspect is, if one doesn't think a randomized controlled trial is ethically acceptable, but you can compare different populations, one of which has been receiving screening modalities, the other which has not, you want to compare outcomes for those kids, you lose the ability to do that if you develop a uniform system. So you don't have natural experiments by being able to compare populations who have or have not had the particular intervention in question.
Yeah, I just wanted to second the motion in favor of variability. I think having every state doing the same thing here is going to multiply the ability to learn from, or diminish the ability to learn from it. So just to take MBAD again as an example, do we want 50 states all at the same time making the same mistake that Wisconsin has made in identifying 23 normal children as having a life-threatening disease? By having variability, there's a chance for Wisconsin to study that problem, having stumbled upon it, and for other states to get the message before they have hundreds or thousands of kids in the same situation. Dr. Rod Howell, who was chair of the ACMG committee, said, as Duane has said, that this is spreading like a house on fire in the New York Times. And my reaction was, if you think it's a good thing to have your house on fire, then that's a good thing. But I don't think we want this spreading like a house on fire. I think we want a measured, careful approach to it. One other comment about this. Duane mentioned an anecdote, a very poignant anecdote about a child who was severely harmed. I can't remember if he died or just had severe damage as a result of something being missed. Of course that will happen. Imagine if CT scans, just to take an example, were free. Let's say there were no cost and they're virtually riskless. If we did CT scans on everybody every day, we'd save a lot of lives. We'd identify some kids and adults with brain tumors that are treatable that would otherwise not be detected. But for every one of those, there would be thousands of people who would have false positive findings, incidental findings that would lead to diagnostic odysseys, tremendous harm. So it's not that nobody benefits from screening everybody for 50 disorders. Of course some kids will benefit. The issue is how you weigh that against the risks, which, again, if you take this on, it's going to be different for each disease, but I just take MBAD as an example because it's easier to use documented examples. The numerator is 0. That is the benefit we've identified in Wisconsin so far is 0, and the denominator is 23. So it'll be different for each disease, but we won't know what it is unless we study it. And I don't think we want 50 states to be doing the same thing when there's no knowledge about any of them.
Penny, did you want to add anything about the adequacy of resources in place with regard to counseling these families?
Well, I think that makes a big difference in having those resources, and there's probably a lack of it for quite a few, but that's the obligation that we have, is making sure that the resources are available, and as you bring up that there are a lack of giant counselors and others than that trying to create those resources and put them in place. But in Washington State, we've really tried to, because we just expanded the newborn screening this Monday, so it's been a big process up to now, and now it's a lot of work, but making sure that we have those available for the families once these conditions are identified in the families. So, but we do need the funding, I think, also to be able to, so it gets back to this about the need for funding, whether it's federal funding or whatever, so.
Over here.
Ralph Verboyen from University of Washington. Dr. Fost's comment about CT scans I think is interesting because we live in a direct-to-consumer advertising age, and it seems that a lot of the discussion this morning has been about mandated testing, but I thought a lot about Dr. Tarini's example of seeing a patient in 2020 and going over many results, and I worry about families choosing genetic testing that is outside of a screening, how available that's going to be and what sort of implications that'll have on resource allocation, access to resources and things like that.
And I believe there's already direct-to-consumer advertising going on for genetic screening. So does anybody want to take that on?
I think the point you're raising, I certainly agree with the concern. I think a lot of people agree with the concern. The point you're raising really has to be, I think, analyzed at two levels. One is to what extent are tests out there claiming that they provide information that they don't, that are in essence fraudulent. And because we have limited regulatory oversight of new genetic tests, there is some potential for that. In fact, a recent paper from CDC suggested that 60% of direct-to-consumer tests actually lack an evidence base even to support the risk relationship. The other, assuming that we can figure out some perhaps regulatory scheme to, which would involve pre-market review to solve that problem. I think the other is really what I would call a medical commons problem. That is direct-to-consumer tests that offer risk data, which is valid, so the tests are not fraudulent, but the clinical significance is unclear. The information is there, it perhaps provides some personal value, but it isn't clear that it provides clinical value in terms of informing decisions to improve health outcome, is likely to result in people bringing that information to their docs and spending time. And in fact, that's another example of sort of the hidden part of the iceberg, the potential for very significant costs to be basically taken away from other kinds of healthcare activities and devoted to discussing this kind of information. I think that's a genuine concern.
There is no way this problem, direct-to-consumer advertising is one thing, but consumer awareness of this is obviously going to multiply. They have access to the same information we do. There's no way that problem can be solved with people. That is, there's not enough, we can never generate enough genetic counselors to handle all that. Doctors and offices have no chance of keeping up with this information. The amount of time a pediatrician spends on anticipatory guidance is 90 seconds. You're going to add to that 1,000 microarray test results and so on. So this cannot be solved with the present paradigm. One possible solution, to make another constructive suggestion, is better interactive computer programs. Michael Green and I have done randomized controlled trials of an interactive computer program for BRCA1 testing, in which consumers, high school graduates, did as well or better with the computer than they did with an hour with a trained genetic counselor, understanding the extreme complexities of BRCA1 testing and what it means and what false positives are, what the treatment options are, and so on. This is cheap, it's immediately accessible to the whole population, at least people who are literate enough to understand it. So it's another initiative I'd like to see NIH and DHHS embark on. Is way more money, just more research is not needed. It's very clear that interactive computer programs are much more effective and efficient than healthcare providers, counselors or doctors and so on. Oh, no, it's just because the patient has infinite time to spend with them. They can take it home, they can go over it over and over again, they can be assessed, their knowledge can be assessed. There's 10 reasons why it's more effective. But what's needed is just money to develop a program for each one of the 55 things on the metabolic screen and for the 1,000 that are going to come on the genome thing. We just need computer technologies to make this information accessible to doctors and to lay people.
I would also like to make sure that there is education of the medical community as well, because I've seen a lot of misinformation given to families by the primary care provider and that, and I would hope that there's also enough genetic counselors or geneticists that we can have as a follow-up, because I've seen a lot of individuals misinterpret what the computer is telling them, and so.
Absolutely. One of the slides I skipped over quickly was there's a gene called 5T in cystic fibrosis screening. It almost never leads to cystic fibrosis. There have been 250 at the minimum women who have had amniocentesis purely because of a 5T mutation, who were really at no risk for anything, and there have been terminations, there have been abortions, because doctors and testing companies gave them misinformation. There just needs to be much more information that's readily available to doctors, to testing companies, as well as to lay people. I agree.
In the interest of making sure everyone gets fed, I think we'll take one more question from over here.
Hi, I'm John Toomey. I'm from Massachusetts General Hospital, and I'd like to ask Dr. Tarini and Dr. Fost particularly about the Wisconsin experience in CF newborn screening testing. The scientific literature seems pretty enthusiastic that it's a successful experience because of the nutritional benefits that that group of newborns that are diagnosed right away, rather than those who would have been diagnosed a little bit later in life, the nutritional interventions. On the other hand, with the knowledge that there's also a large group of carriers who are identified and obviously don't need to have any interventions, plus the concomitant time that needs to be spent with the parents, counseling them as they go through the experience. Is CF newborn screening the model that's going to tell us that we should do other screening for those illnesses which are not emergent at birth, but perhaps the urgent model that was identified during the talks? Thanks.
Well, we need an hour, and we just have a few minutes. I was a co-investigator on that study with Dr. Phil Farrell, who led it. It's possibly the largest clinical trial ever done, 600,000 children randomized. It's one of the few newborn screening tests that was subject to a really careful, well-designed, prospective, randomized clinical trial. The results showed that the early diagnosis and early intervention group are taller and fatter, as Dr. Farrell likes to say, but that's a surrogate measure. What really matters is, are they healthier? Are they going to live longer? Do they have less hospitalizations and so on? And that's mainly about lungs. On the lung side, they came out worse. They had earlier exposure to Pseudomonas because they were brought to a clinic where Pseudomonas was rampant. They developed Pseudomonas, drug-resistant Pseudomonas infection more quickly than the control group. Their x-rays were worse, which generally predict pulmonary deterioration. So you had a randomized clinical trial that on the major outcome measure that affects morbidity and mortality came out worse, and what's happened, it's been implemented in now almost every state. It's certainly near that. So if that's a model, it's a very concerning model, because here we went to all this trouble. It would be like doing a trial for a drug, and it comes out that it hurts people in a very bad way, and you say, oh good, let's give it to everybody. So Dr. Farrell and I have a longstanding disagreement about whether the benefits of being taller and fatter, which is to me is a surrogate measure, outweigh the objective. Now this adverse effect of early Pseudomonas acquisition is potentially preventable. I mean, you could take measures in clinics, but I was just talking with a person who's responsible for the CF program in California, who points out it's not so easy so it's theoretically a solvable problem, but that's just one problem. The carrier problem is another one. We had trained genetic counselors advising all the parents of false positives kids who themselves were carriers, and a year later we had the predictable very high rate of confusion, irrational reproductive decisions, parents who think their kids have cystic fibrosis who don't. So despite extremely careful counseling by very skilled counselors, we had this irreducible confusion and stigmatization rate.
On the heels of that, and the mention of California, there's a model of cystic fibrosis screening that is germane to the image I gave of the iceberg that is likely to take hold as we move forward with screening and with advancements in the development of genetic technology. And that is, as we fight to identify all children, every last child that could have cystic fibrosis, and we broaden our diagnostic criteria to include genetics, we may end up with more ambiguous cases than we once thought we would. An example being, and I don't know if there's anyone from California in the room, but California has a standard by which the IRT is the first phase, followed by genetics, and also by a sweat test. Now, there are times when it's either difficult to get a sweat test in a newborn, or it turns out normal, and we're not quite sure if it's a false negative. Alongside, so it doesn't tell us much. We have a high IRT. Alongside that, California does a genetic panel, a limited genetic panel. My understanding is if one of those genetic panel lights up, then a more exhaustive panel is done. And when you search exhaustively, you find things you may not have expected to find and about which you may know very little. And there have been cases in California from colleagues there who say, I'm now left with a child who has a newborn who has a normal, if not unable to obtain sweat test, and genetics that are not quite normal. They don't have Delta F508, they don't have mutations, they have mutations I've never seen before or have been described in one case. And so you are left in this mode of cystic fibrosis screening, which I would argue is generalizable easily to many other disorders. You are left telling the parents, I'm not sure if your child has cystic fibrosis because they are normal at birth, and I don't know what these genetics mean because we don't have enough information, we don't have the research infrastructure yet established to know that. But it is a warning sign of what may be to come if that model of screening is generalized ahead of our knowledge.
Jeff?
Yeah, I think CF may be a model for other types of conditions already with respect to this question of treatability. And I think that oftentimes that word is used rather loosely in conversation, and I think we may get the impression that treatability means like congenital hyperthyroidism or PKU, where there's truly a dramatic difference between kids who receive the intervention and those who don't. I think for many of these very complicated metabolic conditions, even when a treatment exists, the improvements in morbidity may be modest. And then it's a significant challenge to decide what is a significant enough benefit to institute population screening on that basis. So with CF, if benefits had been limited to some weight gain and some height gain over time, I think it remains a legitimate question. Is that enough of a benefit to these kids? A legitimate benefit nonetheless, but enough of a benefit to initiate a program of that sort? And do those benefits outweigh the types of harms that we've been outlining as well? And I think for many of these complicated metabolic conditions, these kids remain seriously or significantly ill with significant disabilities, and an intervention may delay serious disability for a period of time or may reduce overall morbidity. And those are, again, legitimate, important benefits, but I think we have to then tackle the problem of are those benefits sufficient to initiate screening every child in the country for that outcome.
Let's thank our morning speakers and panelists.